Welcome to Pinpoint Monday on 88.5 FM and WMNF.org. I'm Sean Canan. Florida is likely to pass 1 million confirmed coronavirus infections today. Nearly 19,000 Floridians have died, and the virus is surging nearly everywhere in the U.S. One American is dying from COVID-19 on average every minute. Today, we'll talk about the latest coronavirus news in Tampa Bay and beyond. And later in the show, we'll take your calls. I want to give out the number that you can have to join this conversation. It's area code 813-239-9663. You can also email dj@wmnf.org. You can text 813-433-0885. Please put your name. Joining us on the show today via Zoom is Dr. Jason Wilson. He's the medical director of the Clinical Decision Unit at Tampa General Hospital. Welcome back to WMNF's Midpoint, Dr. Wilson.
Hey, Sean, I'm happy to be here.
Thanks so much for joining us. Well, let's begin with the local picture of the pandemic in Tampa Bay. What do we know about how many infections there are, the infection rate, and how hospitals are handling the capacity right now?
Sure. Last time we talked, I divided the overall pandemic in this area into a couple different phases. We talked about the spring, March, April, and May as being a period of time where we kind of prepared and got ready for things, but cases sort of hung around 5 to 6 per 100,000. So not super high levels. And then we saw that very large spike in late June and throughout July, which started to slow down after we saw the mask ordinance and a number of other public health measures come into place, and got some stabilization around late August or so. From late August through mid-September, we were really flat with our numbers, and that was a good place to be. But since then, what we've seen is a steady decline up in our numbers, and that incline since mid-September has continued. Now, the interesting thing is it's not a overnight surge. It's just sort of a steady burn. If you look at 2 weeks ago, we have a higher number of cases than we did 2 weeks ago, and 2 weeks from that, we have a higher number of cases there. And so what that's allowed us to do in the hospital setting is still manage our capacity in some reasonable ways. So overall, the capacity is less than we had before, but we don't have quite yet that horrible surge we had in July.
Our guest is Dr. Jason Wilson. He's the medical director of the Clinical Decision Unit at Tampa General Hospital. We're talking about coronavirus numbers right now in Florida. I got these numbers from the Tampa Bay Times yesterday that in Tampa Bay, 20% of hospital beds and 22% of intensive care unit beds are available. That's very similar to the state of Florida numbers. What would you say about that number? Is that something that frightens you, or are we in good shape with those numbers?
Yeah, I think what we have to do is just be very cognizant that those numbers change very, very rapidly. We were in a place, back in the summer where we were having to recreate capacity constantly. And so sometimes those numbers can even be a little confusing to look at, because if we're constantly recreating new space, the number may stay flat, right? Because we've added new additional beds, or we've moved beds around, adding to what the overall denominator is in that equation. So it's good that we have beds. I mean, certainly that looks better than North Dakota or somewhere else right now. And I go back to, one of the things in this area that happened that's probably allowing that capacity to take place is this large West Central Florida Information Exchange dashboard that we do have. And it's something that other places, don't have, which is where over 40 hospitals in this entire Gulf Coast region are sharing information across systems with each other to ensure that capacity remains for each hospital. Obviously, if you have one ICU that is 12 beds in your whole hospital, having 6 patients in that ICU is going to feel very, very challenging. But a place that has more ICU beds than some other hospitals in this whole area can accommodate so many more patients. So watch those numbers closely. They change very, very rapidly. Certainly it is more reassuring that we have beds at the moment. As those numbers change and as that capacity decreases, that's where we really start to worry about things like case fatality rates and the ability to take care of each individual patient with tailored care.
And another number that we look at is the positivity rate. So when people go to get tested, what percentage of those tests are coming back positive? Right now, Florida's average weekly positivity rate is about 7.8%. We hear a lot about the 5% target. So can the 7.8%, could that indicate that there is not widespread enough testing to capture people who are asymptomatic? Is that what that might indicate? And so the spread might be actually a little bit worse than we're seeing?
Yeah, so you brought up a couple of good points. First of all, yeah, you're that whole overall number, 7 to 8%. That's still a very high number for positivity. To really get a hold of this virus and for public health measures to have their best chance of working. And what I mean by that are things like contact tracing, for social distancing measures to really have their best effect. Try to get less than 5%. Under 5% is really where we want to be. Now, as we go up over that, it becomes harder to do things like contact trace. More and more people are contacts. So who are you tracing, right? As you get higher and higher. And certainly when we were up, this summer into the 15% or higher range, it was, virtually impossible to use any of those preventative measures. You were past containment. That was out in the community. Now, to your other question, which is also very important, we always assume that there are some number of patients, of course, who are positive, who have not been tested because they are pre-symptomatic or asymptomatic. And what we would expect is that as testing increases, the positivity rate should decline because more and more people are getting tested. And so, while that has happened to some extent, right, we're not seeing 15 or 20%, we're still seeing these very, very high numbers. So we know there's still some what we call like ascertainment bias. There's still some number of people we can multiply the actual positive number by, and know those people are out there too that are actually positive. Whether that's 5 times the positivity number is the real number or 10 times, it's probably something like that, but it's most likely higher than what we actually see in those positivity numbers.
We're speaking with Dr. Jason Wilson. He's the medical director of the Clinical Decision Unit at Tampa General Hospital, and you're listening to 88.5 FM WMNF Tampa. This is Midpoint Monday. I'm Sean Canan. Speaking about how many people might actually be sick out there, a new study from researchers at the Centers for Disease Control and Prevention estimates that only about 1 in 8 coronavirus infections nationwide were reported through the end of September, which means that the undercount could mean that the true number of US coronavirus infections could be closer to 52.9 million. Do you know much about that study and how good that estimation might be?
Yeah, overall, we've seen a couple of studies that sort of triangulate this estimate somewhere between that 5 and 10 times number. As a matter of fact, the Georgia Tech site that's become very reliable in terms of estimating your risk if you are going to a place, depending on what the prevalence of COVID is in the community, what the likelihood is of somebody else in that space having COVID, depending on the size of a gathering, uses a similar estimate, and it's a range, and every study is going to look a little bit different, but it seems to be somewhere between 5 and 10 times the number that you're seeing as the positivity rate is the true rate in the overall community. Now, there's been a couple of studies since the spring that had higher numbers, but those were done kind of at the peak of the outbreak in dense areas like the middle of New York City, in a neighborhood that had a very high outbreak number, or in Santa Clara County during a period of time with a very high outbreak number. But overall, if we look at it, those numbers seem to be closer to that 5 to 10 times number. Now, some of the antibody studies haven't really matched that. We have seen other studies where we take antibodies of people, of communities, and try to get a sense of where they're at, and specifically in healthcare workers, and they've been much lower. And so one of the good things about that is it means that we're probably pretty well protected right now at the PPE and the things we're doing in the healthcare system compared to just that asymptomatic spread that's going on in the community. In other words, what I'm saying here is that there's probably likelihood much higher rate of true positives in the community than there are in the healthcare system, the actual people taking care of COVID patients, which means at least the things we're doing to prevent getting this from patients or giving it to each other as healthcare workers seems to be working pretty well.
And when you say antibody studies, what you're doing is you're taking blood samples from people and measuring these proteins called antibodies, and people would have certain antibodies if they've been exposed to the infection, to coronavirus.
Yeah, that's right. So, yeah, after about 10 days of exposure to COVID, exposure meaning that you've actually had viral, infection or into the body, and mounted some type of, immune response based on that exposure. About 10 days afterwards, over 90% of people will have antibody in their blood serum for COVID. And so we do measure that. So that's not an acute study. We don't do an antibody study to test and see whether you have acute COVID right now. But that's what we would do to see if you've had COVID and didn't know it, or if you've kind of recovered from COVID essentially.
Our guest is Dr. Jason Wilson with Tampa General Hospital. This is WMNF Tampa, and it's 12:16 in the afternoon. Dr. Wilson, I want to ask you, and people may have heard this many times over the last 9 months or so, but I think it's worth going over again. What are the best ways to slow the spread of this virus in the community?
Yeah, and it's a very boring message at this point, but sometimes the boring messages are the most important messages. We have, and one of the things about the boring message is at least the boring message comes with some pretty strong data at this point as well that it reinforces the boredom works. And what do I mean by that? So washing your hands still sounds so simple, still sounds not as sexy as an mRNA vaccine and things like that, but obviously, wash your hands can very much decrease any virus transmission. Wearing a mask. So we now know not only is wearing a mask essentially a free or a very very cheap intervention, a public health strategy. It's also essentially a harmless intervention as well. So in the risk benefit equation, this is all benefit with really no risk. We've definitively seen data from basically every county and every state and every place that's implemented mask mandates that we've seen decreases and declines in COVID numbers a couple of weeks after those went into place. We saw that here in Hillsborough County after the June 26th mask mandate. We've seen it in other places as well that have put that data out. Not only that, though, we've now seen data too that says that not only are you protecting other people from getting COVID from you, you're protecting yourself, much more strongly than we even suspected at first. You're protecting yourself from getting the virus, even with these cloth masks and under medical grade mask, which is a pretty promising. So again, a cheap and widely available intervention. And then, social distancing. We talked about the likelihood that 5 to 10 times the number of people who've actually tested positive have symptoms right now, have known COVID. So that means 5 to 10 times more people have COVID. So the likelihood that you're around another person when the positivity rates are over 5%, is at least 10% when you're in a crowd of 10 people. So we want to make sure we avoid those interactions, especially in indoor spaces and especially less than 6 feet apart. It's a respiratory virus that, in the beginning of this pandemic, we weren't sure how it spread. We were very careful that it could be contact virus or fomites on contact surfaces. And it seems much less spread that way, much more spread by just respiratory droplets that I could expose you to if I had COVID and was coughing in your space, or, just, sort of spit coming out when I talk in a space. So just moving back 6 feet gives the vast majority of those droplets a chance to fall to the ground. And the ones that don't, when you wear a mask, the vast majority of the rest of those droplets can't get through the mask. So you've really decreased quite a bit of transmission there. So tried and true messages you've heard since March now, they're still very effective. And honestly, if we were all doing those things, we would have had this thing under control a long time ago.
You're listening to Dr. Jason Wilson. He's Medical Director of the Clinical Decision Unit at Tampa General Hospital. This is WMNF's Midpoint Monday at 12:19 in the afternoon. You can email a question to dj@wmnf.org. You can text 813-433-0885. I'll take calls later on in the show, 813-239-9663. A lot of how you answered that reminded me kind of why I wanted to go over the having the precautions talked about again and again. And part of it is because we knew very little about this novel coronavirus 9 months ago, and we were getting mixed messages. We were getting different messages about masks, but now we know masks really work. And I'm talking now about cloth masks as opposed to even the N95 masks, which not everyone has access to. So I'm glad you pointed out how we've evolved our knowledge, and how now that leads us to having really accurate ways of knowing what to do. Let's turn now to vaccines, if you don't mind. What can you say, first of all, Tampa General Hospital, your hospital has been announced that it will be one of the first hospitals in Florida to receive vaccines. We're hearing there might be some vaccines approved as soon as in 3 or 4 weeks from now, maybe. What can you tell us about the timing and the efficacy of the first vaccines that might get rolled out?
Sure. So, from a vaccine standpoint, what we've seen is really a moon landing level of scientific endeavor, which has taken place in a very challenging time for science, I would say. So, I think there's some excitement there just as a scientist, and the amount of development we've seen in this vaccine area. You've got a number of different pharmaceutical companies, of course, that are racing to get a vaccine to market, and really trying quite a bit of newer sounding technologies to get there. So the Pfizer and Moderna vaccines we've heard the most about right now and see the most data are using an mRNA technology, which is something that's been studied for a while in the cancer space. Moderna's been working on a HIV type of mRNA vaccine for a long time. It's been a very exciting type of technology. It's not new for safety. What I mean by that is there is different clinical trials out there, maybe not for COVID, but for other types of mRNA attempts at vaccine, where this seems to look pretty safe for humans to use a mRNA style vaccine. And what's really novel about this type of vaccine technology is it's not what we've seen before, where we might have taken viral particles and either attenuated them, meaning made them mute so they couldn't hurt anybody, or killed them, and then exposed serum, the body to that to try to mount antibody. Instead, here what we're actually doing is essentially giving you the instruction booklet. In a little package, we're giving your cells the instruction booklet to build their own and build it at any time. And what are they building? They're building a very specific protein that lives on the wall of this COVID virus. So you mentioned we know much more about this SARS-CoV-2 novel coronavirus than we did in the spring. One of the most important things that happened globally last spring was in China, they sequenced the genome for this virus. And that was a critical decision, because that allowed the vaccine race to start right there. By having that sequence and using this new mRNA technology, you could begin to start to target that genetic sequence with gene technology. And then also understanding this, what's become both in a therapeutic space and a vaccine space, this little spike protein. Spike protein is a little protein that sits outside of the virus, and it's like the door, or the key. I'd say the key to your cell's door. It's what unlocks the door and lets the virus into the cell. And by targeting that spike protein, you could think about treatment for the virus. You could also think about vaccine for the virus. And so that's how the vaccines are being developed, is by focusing on the spike protein. So these mRNA vaccines, which is both what the Moderna and the Pfizer vaccines are, they're both mRNA vaccines, both target this spike protein. They give the cell instructions to make spike protein. And by the way, that's all this mRNA instruction booklet tells it to do. So in terms of safety, think about it like going to IKEA and buying the chair. All the instruction booklet you get is to build the chair. So, even 10 years later, if your cell picks up that instruction booklet, the one thing it knows how to do with that instruction booklet is build that same chair again. So it can't do anything else. That's what it can do, is build the spike protein, which then allows your body to specifically make antibody against spike protein. And so we've seen the Pfizer and Moderna vaccines both do this. We've seen at least some good data that they have released, that the companies have talked about. We have not seen a large published phase 3 clinical trial yet, which means that the companies are giving this data to the FDA. And the FDA's experts, and they do have world-class experts in vaccine review, will review that data. And then if that data looks like the company says it does, and the safety standards are met, we would expect that the first vaccine would probably be approved somewhere around December 10th, which is you've got Pfizer's put the application in and Moderna's put the application in just today. But the vaccine committee will meet on December 10th. And we would expect that if the results look as promising as they said they did by the companies, then the FDA would issue a favorable review, and we would see that report as well, which is reassuring for the public, especially I think now the FDA is under much less political pressure to issue a fair and transparent report. We would see that report and then expect vaccine availability really right after that. We know now that Pfizer is moving vaccine through the distribution supply lines even as we speak.
And just to be clear, you said this, but I'm going to put it in slightly different words. Even though you're getting mRNA, which is nucleic acids, which might sound frightening to people who have seen Jurassic Park or something, even though you're getting mRNA, it's completely harmless. It can't create it can't create the virus inside of you. It's only a specific portion of the mRNA that will just give you the instructions to create this one protein.
That's right, John. And so this mRNA can't jump into other places. It can't jump into your genetic sequence. There's, there's enough clinical study about this technology around now that we know it doesn't really do anything else. And so it just reads that instruction booklet over and over again and creates that same protein, as over and over again. That's really all this mRNA technology would do.
Our guest is Dr. Jason Wilson, Medical Director of the Clinical Decision Unit at Tampa General Hospital, and we're talking about all things coronavirus. Right now we're on vaccines, and we'll get to some other things hopefully soon in a few minutes if we have time. But staying on the vaccines, these two vaccines that we've talked about so far, since they are mRNA vaccines, they require freezing at sub-zero temperatures, something like 70 degrees Celsius below zero, which is not your home freezer. It's a specific type of freezer that you would have to have. So it would make the portability of this vaccine a lot more challenging. Do you think that this will? I kind of know the answer to this question, but because of all of that, will this be the only vaccine type that we'll need, and we won't have to rely on any other kinds, or what are other kinds of vaccines that might supplement this?
Sure. So you nailed it. This is a pretty specific technology where you have to have organizations, institutions that can handle a negative 70-degree storage. And that means moving it around on dry ice. That means, storing at a negative 70 temperature, which is basically at research institutes. That's why you're seeing the vaccine go to, I think, 5 hospitals, in the first wave, is because those are places that can store it safely and act as distribution sites and have done this type of research before. And that's why those places will get the vaccine. So that leaves a lot of room, not only because even one company can't vaccinate the entire world, right? At the scale we need to this quickly. In addition, even in Florida, we can't get past 5 sites at the beginning wave. So how would you do this to the developing, the low and middle income countries and other places that aren't going to have negative 70-degree temperatures? That leaves open room for other types of vaccine supply lines and other types of vaccine technology. AstraZeneca, for example, is using a more tried and true technology of using what's called a viral vector. So taking like a very common cold virus, essentially attenuating that, but using that common cold virus kind of like a Ford Explorer or something. That just acts as like the vector to get you down the road, and you kind of pile in what you want to in the back seat and you move it into the cells. So it uses a common cold virus to pile in the technology to actually fight COVID into the back seat and put that in the cells. Now, unfortunately, the AstraZeneca virus, I think, had some challenges in the data, and we're going to kind of have to see probably what the full data set looks like at this point before that one can move forward. But that one was designed to really try to be available in more more difficult to access countries and places that might not have some of this technology that we have afforded to us here.
Our guest is Dr. Jason Wilson, the Medical Director of the Clinical Decision Unit at Tampa General Hospital. I don't know, do you have a couple of more minutes, or do you need to get going right now? Okay.
No, we're fine, Sean.
Thanks so much for staying on then. During the pandemic, there have been times, especially at the beginning, where there was a huge shortage of personal protective equipment for first responders, for people in the medical field. Also, there have been log jams with testing supplies. Where do we stand right now as far as nurses and doctors being able to access PPE and also being able to administer as many tests as we need to.
Yeah, certainly a better place than we were. One of the problems was that the supply lines logistically that we had for PPE, for test kits, for laboratory supplies, they were established and they weren't very varied, right? Everybody kind of used the same manufacturers and the same logistical suppliers throughout the globe. And so when you saw a pandemic, a global pandemic happen, everybody was trying to get supplies from the same supply lines they'd always used, and that created a logjam. And then you had a couple of places just run out of stuff, or places that were going through their own pandemic. Italy is a big manufacturer of those test kits, and so when Italy was going through a pandemic in the spring, obviously there was a decline in the number of those kits that were being produced. So what happened in that space is that other logistical chains started to open up and be created or reified a bit. And other companies, of course, started to develop their own testing. And many, including Tampa General in this area, were able to stand up their own types of tests. And then USF helping to actually make their own test kits for Tampa General using some 3D printing technology, which was really what saved us during that lack of availability of testing. So testing's more widespread than it was previously. However, if you look at the recommendations for the number of tests that should be taking place, especially in the absence of widely available vaccine technology, we're still not where we should be with testing, right? I mean, the technology exists that by just technology wise, that we could be having home testing, through some type of saliva PCR, but the reasonable availability of that is still a pipe dream at this point. If you think about going back to March and trying to come up with a national public health mission to get to a place where we could have widespread repeat availability of that type of testing technology, both in homes and businesses and across community events, we may have met that goal by now, because we're starting to see that for very niche or very specialized populations. So if you look at things like professional sports leagues, for example, right? The ones that have employed really dedicated testing strategies and public health measures, like the NBA and NHL, they were able to do widespread testing and really create pretty reasonable containment. Now, the other big sports league, the NFL, has really struggled in the past couple of weeks, but that's a league where you see a lot of travel and also fans in the stand too, which you do not see with the NBA and NHL. So still some pretty significant challenges with testing, but better than we were, 6 months ago.
Before I let you go, Dr. Jason Wilson, I want to ask, how do you talk to COVID deniers? What kinds of strategies can people have in their toolbox when they encounter someone who, whether it's masks or whether it's just that whether the virus even exists or not? How do you talk to people like that?
Yeah, it is tough, and one of the sad things is at this point in the pandemic, more and more people are having personal experiences where it becomes harder to deny. So just like how HIV was, through the 80s and 90s, or just like having a person in your family who's LGBTQ, whatever. Eventually, once you experience that in your own family, it becomes hard to deny the clinical reality that these things exist in the normal variation of humanity. And that this COVID virus exists and it makes people vulnerable into humanity. And so I think that unfortunately that experience that people are having is meeting reality. But when I encounter people like that, I try to tell them about my personal experiences that I've had in the healthcare setting. And in that healthcare setting, we've seen some very critical sick people. We've seen people die alone. We've seen people have to use Zoom and FaceTime to talk to their family members as they depart the earth. And I think that's something we would all want to avoid. And again, wearing a mask is a pretty harmless, piece of technology. So I think, unfortunately, we're witnessing the same type of denial that, we've seen with any other very challenging pandemic throughout the history of this country. But as the humanity of more and more of us experience in our own families, and I always say the clinical reality trumps everything. The clinical reality is you can't escape what this is. The more we see that, the more I think people have to come around to where we're at right now. And the other thing I mentioned, I always remind people of, the vast majority of Americans in this country do recognize the seriousness of this virus. And the vast majority of Americans are trying to do what they can. They just need a clear message as to what those recommendations are for doing the right thing. And the more we can be consistent about a clear message of what the right thing is, I think the better, our neighbors will do to protect each other and us.
Well, Dr. Jason Wilson, thanks so much for coming on Midpoint today.
Oh, I'm happy to be here, Sean. Sorry, some of these circumstances.
Yeah, me too. All right. Well, thank you. Thanks so much for joining us. Dr.
Anytime.
Jason Wilson is the medical director of the Clinical Decision Unit at Tampa General